Hello, my name is Luis Miguel Rodriguez, a family nurse practitioner student at West Texas A&M University. Today I'll be presenting a complex psychiatric case for my current clinical semester. This presentation will follow the SOAP format and demonstrate the integration of population health, systems-based practice, and informatics as they apply to advanced nursing practice. RK is a 37-year-old Hispanic female with a past medical history significant for hypertension who presents today with anxiety and a persistent feeling that her world is caving in. Her chief complaint today is anxiety. The patient reports that her anxiety began approximately 1 year ago following a divorce related to spousal infidelity. Since that time, she describes ongoing and excessive worry, emotional overwhelm, and difficulty coping with daily responsibilities. She reports that her symptoms are chronic rather than episodic and interfere with her ability to relax, focus at work, and manage her responsibilities at home. She denies experiencing panic attacks, but endorses constant worry related to financial stress, occupational demands, and parenting as a single mother. She denies chest pain, shortness of breath, dizziness, or pain today. She also denies suicidal ideation, homicidal ideation, hallucinations, or delusions. She has no history of psychiatric diagnoses, treatment, or hospitalization. Her past medical history is significant for hypertension. She reports no significant family medical or psychiatric history. Her social history is as follows. RK is a divorced and is the primary caregiver for two children, a 16-year-old son and a 13-year-old daughter. She works full-time as a dispatcher for a trucking company where she schedules load pickups and deliveries. She has held this position for 4 years after transitioning from previous employment as a barista for Financial Opportunity. She identifies work-related stress, financial responsibility, and single parenting as major ongoing stressors. She denies tobacco use, alcohol use, and illicit substance abuse. Her current medications include 10 milligrams of lisinopril by mouth daily, uses Tylenol, 500 milligrams, PO, BID, PRN as needed for pain or ailments, headaches, which she does not currently have. She reports no known food or drug allergies. No pertinent physical positive symptoms voice. Psychiatric review of systems is positive for anxiety, excessive worry, and difficulty relaxing. Denies feeling of hopelessness, depressed mood, significant sleep disturbance, appetite changes, or suicidal or homicidal ideations. For a physical exam, her vital signs were as follows. Her blood pressure is 144/90. Her heart rate is 102 beats per minute. Respiratory rate is 20. Temperature is 37 degrees Celsius. Oxygen saturation is 97% on room air. Her weight is 140 kilograms. Her height is 166 centimeters, which leaves her at a BMI of 50.8, indicating class 3 obesity. On her MSE, her mental status examination, the patient appears well groomed and appropriate for her stated age. She is cooperative and mildly restless. Speech is normal in rate and tone. Her mood is anxious with affect congruent to mood. Thought processes are linear and goal-directed. Thought content is appropriate with no evidence of delusions or hallucinations. Her cognition is intact, and she is alert and oriented to person, place, time, and situation. Insight is fair, and judgment is intact. Overall, the patient presents with chronic anxiety accompanied by physiologic manifestations, including tachycardia and elevated blood pressure. consistent with a sustained stress response. Um, as far as assessment goes, our primary diagnosis is going to be generalized anxiety disorder. This diagnosis is supported by excessive anxiety and worry lasting longer than 1 year, difficulty controlling worry, functional impairment, and associated physiologic symptoms. Her differential diagnoses include adjustment disorder with anxiety, which was considered due to the identifiable stressor of divorce, but ruled out due to the prolonged duration of symptoms. Major depressive disorder was also considered, but ruled out due to the absence of persistent depressed mood, anhedonia, and neurovegetative symptoms. From a population health perspective, this patient's anxiety is influenced by social determinants of health, including marital disruption, occupational stress, financial responsibility, and single parenting. These factors contribute to chronic stress exposure and increased risk for both mental and physical health complications. For her plan, pharmacological management includes initiation of sertraline 25 milligrams by mouth daily, with a planned increase of 50 milligrams after 1 week if tolerated. Lisinopril 10 milligrams daily will be continued with close monitoring of blood pressure, as anxiety may be contributing to poor hypertensive control. For her non-pharmacological management, interventions include a referral for cognitive behavioral therapy to address the maladaptive thought patterns and improve coping strategies. Lifestyle recommendations include stress reduction techniques such as mindfulness, improved sleep hygiene, and gradual increase in physical activity as tolerated. Safety plan. The patient denies suicidal or homicidal ideation. The crisis resources were reviewed with the patient, including the suicide hotline, and the patient was advised to seek immediate care if symptoms worsen. As far as follow-up is planned in 4 weeks to assess symptom response, medication tolerance, and blood pressure control. This plan reflects systems-based practice by coordinating pharmacological treatment, psychotherapy referral, and primary care follow-up to address both mental health and chronic medical conditions. Informatics supports care through the use of standardized screening tools such as the GAD-7, the electronic health record documentation, and the clinical decision support systems to guide evidence-based medication management and follow-up. Paplow's nursing theory of interpersonal relations guided this patient's care by emphasizing the therapeutic nurse-patient relationship as central to reducing anxiety, improving insight, and supporting engagement in treatment. In summary, this case demonstrates the importance of patient-centered, evidence-based psychiatric care that addresses psychosocial determinants of health while utilizing interprofessional collaboration and healthcare technology to improve outcomes. Thank you.